This is our presentation for the healthcare in the United Kingdom.
My name is Olivia Dodge.
I'm Lucy Gregg.
I'm Ashley Guazo.
And I'm Mallory Hamilton.
So, some important factors of UK healthcare that we need to understand is the coverage, the financing, the payment, the delivery of healthcare services, and the pharmaceutical coverage. To start, we're going to begin with coverage. The United Kingdom's healthcare has two main branches. It has the NHS, which is the National Health Service, and it also has VHI, which is Voluntary Health Insurance. The NHS is widely used as it covers everyone living in the UK. Voluntary health insurance is utilized by just under 11% of the 66 million UK citizens. This is approximately 7,260,000. The NHS works like this. It's a single payer socialized system. You must be a UK resident, and patients can choose who they want as their primary care physician or general practitioner. According to the National Library of Medicine, a single payer socialized system just means a healthcare system that is financed by a single entity. In its common usage, that single entity is the government. Being a resident of the United Kingdom is enough to get you NHS coverage, but better yet, you can receive care anywhere. This means that if you travel to a different county, you'll still be covered. When a patient decides who they want as their primary care physician or general practitioner, this person then becomes the first point of contact. They will have the responsibility of making referrals to specialists, hospitals, and other more specific forms of care. Hospitals and ER visits are also free of charge. So then covered services include, but are not limited to, in and out of patient care, prescriptions, mental health services, dental care, and care for vision. Non-residents will be able to receive care for free with the exclusion of subsequent care or additional charges. So they'll be able to receive most of their care, and if there's anything like you need an X-ray, an MRI, stuff like that, that comes out of their paycheck. The only extreme apparent issue with the NHS coverage that patients have spoken up about is the postcode lotteries. This is due to the fact that certain areas will cover for different services than others. For example, if you've lived in Lexington with the zip code of 40502, you've had your dental work covered, but then you move and need dental work done in another area, saying 40509, it would no longer be covered. So it's just depending on where you live, certain things can be covered versus others. There's also the option for voluntary health insurance. These plans will cover more specific areas of care, such as cancer treatments, elective services. Elective treatments are procedures that are not deemed medically necessary or urgent. Most individuals using this form of insurance are supplied through their employer. Others are paying for it themselves. Within this, there are 9 different voluntary health insurers. Premiums will be decided based on the care the individual needs and receives. However, voluntary health insurance is not as used nowadays because more of the funding is going toward the NHS, so it's more likely that people will use that system. Now moving on to financing. In 2017, the UK spent 260 billion USD, which is 9.6% of the GDP on healthcare. The budget of the NHS is 160 million USD. The greatest non-government expense was in 2017 was out-of-pocket spending, which was 40 billion, which is about 16% of the total spending. And the second greatest cost of healthcare is the purchasing of private insurance. So 260 billion may seem like a lot compared to the United States, but the United States actually spent 3.5 trillion, which is nearly 18% of their GDP on healthcare in 2017. This makes this number seem slightly more reasonable. Of the G7 countries, which is the United States, United Kingdom, Canada, France, Italy, Germany, and Japan, the UK was the second lowest when it comes to the spending of healthcare, falling short to only Italy. Out-of-pocket spending includes, but not limited to, long-term home-based care and residential care. The UK spends a lot of money on their long-term care. In specific, it was 62 billion in 2017. Most of this money came from the government, but the rest was financed by out-of-pocket and nonprofit institutions. In England, patients needing more long-term care assistance are not eligible for financial help unless they have at least 30 grand in their savings. If they need to stay in a nursing home, the value of the patient's current home is accounted for in that 30,000. So whatever they're paying for their house is accounted for in the 30,000. So in 2017, there was an effort to change this amount from 30,000 to 100,000. But this had the chance to raise costs for existing homeowners and was nicknamed the dementia tax. As stated in the book, Boris Johnson pledged to protect you and your grandparents from the fear of having to sell your house to pay for the cost of care. UK spent 13 billion on public health from 2016 to 2017 and 16 billion on mental health services from 2018 to 2019. Most of this money went to the clinical commissioning groups to increase their investments in the specific area of care. Thus, the MHIS, or Mental Health Investment Standard, was created. Still along the lines of financing, mandatory health insurance says that the UK Treasury determines the budget for the Department of Health and Social Care, or DHSC, in England. This budget encompasses the NHS budget. The NHS distributes the budgeted money to the 191 clinical commissioning groups, or CCGs, based on the needs of the population. Funding for the NHS comes from taxpayer dollars, national insurance contributions, and co-payments on specific care perspectives or services. According to the NHS Confederation, clinical commissioning groups were created following the Health and Social Care Act of 2012, and it replaced primary care trusts on April 1st of 2013. They were clinically led statutory NHS bodies responsible for the planning and commissioning of healthcare services for their local area. In 2019, CCGs were responsible for managing 104 billion USD. This money is used for elective hospital care, primary care, community care, emergency care, and medical health care, or mental health care, my bad. The national insurance contributions are income-linked payroll deductions. If you make less than a certain amount annually, you will not have to pay these deductions, but you still receive the benefits. Last but not least is financing cost sharing. The NHS has no health premiums. However, they can still be small co-pays for specific care treatment options. A flat fee is charged when buying prescriptions, but there are exemptions to this rule. Pregnant women or women who just had a baby and children under 16 and those over 60 will not have to pay these flat fees. Care with co-pays includes dental, prescription drugs, fee for prescription drugs, and is becoming less and less, as 90% of the prescription drugs distributed in 2012 were free of charge, and most healthcare services are free thanks to the NHS.
Switching over to the payment aspect of it, for payment of healthcare in the United Kingdom, it is paid through general taxation. About 18% of a citizen's income tax goes towards healthcare, which is about 4.5% of the average citizen's income. The United Kingdom again spent about 260 billion on healthcare in 2017. The areas for these payments include hospitals, physician payment, mental health, long-term care, and public health. Curative and rehabilitative care is the United Kingdom's largest spending category. 65% of total expenditures is from curative and rehabilitative care, 16% is for long-term care, 10% goes towards goods such as drugs, glasses, and wheelchairs, and 5% is used for preventative care. Hospitals are paid by a system known as Payment by Results, PBR. This is a system of paying NHS healthcare providers a standard national price for each patient seen or treated. Payment to public hospitals has about 60% coming from payment by results and 40% from non-PBR financing. Non-PBR financing includes mostly mental health services. For physician payment, specialists and hospital-based physicians are employees of the NHS and therefore are paid by the NHS. The NHS mental health services are primarily purchased by CCGs, which are clinical commission groups, although the NHS does account for 80% of secondary mental health care. Clinical commission groups are groups of GP practices in which they are responsible for commissioning most health and care services for patients. For long-term care, The NHS covers health needs, while most local authorities usually cover social service needs. Public health spending and regulations go through the DHSC, which is Doctors of Health Sciences degrees, the NHS England, and also Public Health England coordinate public health services.
Of care in the UK, we can see that primary care is delivered mainly through general practitioners. These general practitioners act almost as gatekeepers for secondary care. Patients in the UK get free choice of who they want their general practitioner to be. They're typically the first point of contact, and you have to meet with them before moving on to a specialist. General practice is undergoing a structural change in the UK from a single-handed corner shops to networked practices, including larger organizations using multidisciplinary teams of specialists, pharmacists, and social workers. Most general practices employ other professionals on salaries, such as nurses, whose duties include managing patients with long-term conditions, providing minor treatments. In December of 2017, there are about 15,800 nurses working in general practice in the UK. Nearly all specialists in the UK are salaried employees of NHS hospitals. Salaries are agreed upon as part of national contract between the Department of Health and the British Medical Association. Patients are able to choose which hospital to visit, and the government has introduced the right to choose a particular specialist within that hospital. Most outpatient specialist consultants are carried out in hospitals, although a small portion of consultants take place in general practice. General practitioners are no longer required to personally provide after-hour care to their patients. However, general practitioners must ensure that they have adequate arrangements made for their patients after hours. However, there are still emergency departments and NHS hotline through which patients can receive care after hours. Telephone advice is available on a 24-hour basis through the NHS 111 for those with an urgent but not life-threatening condition. Callers are able to speak to a clinician if appropriate after triage. Publicly owned hospitals are organized either as NHS trusts, which there are currently 64 of, directly accountable to the Department of Health, or as foundation trusts, of which there are 142 of, which are regulated by the NHS. Private hospitals offer a range of services, including treatments either available or unavailable in the NHS or subject to long waiting times, such as bariatric surgery, fertility treatments. But these private organizations typically don't have emergency centers, trauma departments, or intensive care facilities. Mental health care is an integral part of the NHS coverage system, and the NHS does cover a full range of services, from less serious illnesses to more severe, and these mental health services are generally treated by general practitioners. The NHS pays for long-term care, whether at home or in a residential facility, for people who need care arising from illness, disability, or accident, including end-of-life care. About 135,000 people were receiving this form of care at the end of 2018 in the UK.
To talk about the pharmaceutical coverage, the National Health Service spends a total of about $24 million on these drugs annually, and this ends up being about 360 per capita, which is, compared to other developed countries, it's one of the lowest levels per capita. And the regulation of the manufacturing, pricing, and marketing of these drugs is determined at a national level. And the MHRA is the agency that is responsible for the marketing, licensing, and they are able to approve clinical trials for these drugs. They investigate the results from those trials, and then they use those results to determine if the drug is safe to be put on the market. And then if they determine that they're not safe or they prove to be ineffective, they can take them off of the market as well. So these pharmaceuticals that are provided in the UK can be over-the-counter drugs, drugs dispensed by pharmacists, or drugs that just are available with a valid prescription. So there are steps to establishing the price of the drugs in the UK. So there is first the NICE approval, and NICE stands for the National Institute for Health and Care Excellence. And this group assesses the cost effectiveness of drugs and the clinical benefits that they have. And then the cost effectiveness is determined based on what's called quality adjusted life year, or it can be abbreviated to just be QALY. And then next you have the TAC approval, and then that stands for the Technology Appraisal Committee. And they are the group that will typically approve drugs that are cost effective, so priced around 26 to 39,000 US dollars for the quality adjusted life year. And then if the drugs are more for like the life-threatening diseases, they can be approved for up to 390,000. So if drugs are prescribed in NHS hospitals, they are free for patients. But if they are from outpatient facilities, they may require a copay of about $11.55. So there are some patients that are exempt from these copayments, and those include children that are 16 and under, people aged 16 to 18 that are in school full-time, adults that are 60 or older, pregnant women, or those that have given birth within the last year, or people with long-term conditions or disabilities. So because this does encase a large part of the population, the majority of the drugs sold on the market are free. And then for those in the population that are not part of that exemption list, there are certificates that people can apply for, and they can either be purchased for a 3-month or 12-month exemption. And then the 3-month is $38, and the 12-month exemption is $135.
United Kingdom's healthcare system definitely achieves universal coverage. The NHS is responsible for all aspects of the United Kingdom healthcare system and in ensuring that all citizens and residents of the United Kingdom can receive healthcare regardless of income or other factors that could limit those in other countries from receiving care.
There are both benefits and drawbacks to the United Kingdom's healthcare system. To start off with the benefits, the United Kingdom residents enjoy access to national health services based on clinical need and not their ability to pay. In contrast, free access to social care services is a means-tested system with different eligibility criteria across the nations of the United Kingdom. For UK citizens and residents who qualify for NHS, the UK provides universal health care. For these people, the NHS covers all aspects of their medical services for free of charge. This includes ambulance rides, emergency room visits, preventative care, surgical procedures, ongoing treatment such as chemotherapy, and there are no copays, deductibles, or excess charges associated with this care. All medications associated with hospital visits are free of charge for residents. Prescription medication at pharmacies is either subsidized or free in the UK healthcare system. The NHS means that there is no insurance company bureaucracy to deal with before or after a patient is treated. There is no possible refusal of care, so there is very much no discrimination in care in the UK. Despite healthcare expenditure increasing over the years, the UK's healthcare coverage system has remained steady and allows UK citizens to enjoy high levels of protection despite against any financial consequences of ill health and minimal out-of-pocket payments. Since 1948, the NHS has shown that it can adapt to changes in the medical field. It has introduced new medical technologies that are innovative and important to patient care now. In other healthcare systems, access to these would be dependent on your insurance cover, which would in turn be dependent on how able you are to pay. But the NHS does not discriminate about socioeconomic status at all, and provides these new medical innovations for any patient who gets treated under the NHS. Despite having this large public universal care. The NHS does offer private healthcare services for those who are willing to and would like to pay for it. The appeal of the private sector in the UK comes primarily from the overburden part of the NHS system. Additionally, in the UK, providers can be compensated for better work. Despite these great benefits of UK's healthcare system, there are some drawbacks. The UK has relatively lower levels of both doctors and nurses, as well as lower levels of hospital beds. So they at times can be very overburdened, and this may result in long wait times or even a lack of resources. It's been said that 6% of patients wait more than 6 weeks for a diagnostic test in the UK, and many wait more than that. Another drawback is you do still have, although you have the freedom to choose your general practitioner, patients typically don't have the freedom to make requests on which specialist they would like to see to further their care. And then another challenge about the UK healthcare system is that healthcare differs often from region to region. So the same treatment that you would get in Ireland may not be consistent with the healthcare that you would receive in London or England. And so if you relocate within UK boundaries, there still may be some inconsistencies of care and some things kind of lost in the transport. And then finally, there has been a surge in the private sector, which has become burden to the public sector of healthcare.
So comparing the UK to the US, first there are similar regulatory authorities. So as previously mentioned, for the prescriptions, the MHRA is kind of their regulatory, like approving drugs or taking them off the market. And in the US, we have the FDA, which pretty much just does the same thing for drug regulation. And then a difference would be the insurance. So in the UK, it's mandatory for everyone to have insurance, whereas in the US, it's fragmented. Not everyone has insurance, and there's a lot of different ways to go about getting that insurance. And then there are the GDP differences. So in 2017, just to kind of give some perspective, the UK spent about 260 billion on healthcare, which was 9.6% of their GDP, whereas the US spent about 3.5 trillion on healthcare, which is 17.9% of the GDP. And then lastly, a long-term care difference. There are just different paths to get to approval of long-term care. So in the UK, patients are assessed to determine if they are eligible to be put into long-term care, and then a social worker places them in the necessary facility, whereas in the US, people are kind of on their own with figuring out if they need to be put into long-term care and how to go about determining eligibility and where to put them.
And these are our sources. We appreciate y'all listening.
Thank you.